It is 8 o'clock. We will go ahead and get started. I want to thank you all for joining us this morning. We're so excited for today's presentation. I just want to remind everyone of a few housekeeping issues. This call is being recorded, so staying on today, you are giving us your permission to be recorded, and this will be posted to the ABIN website. We will get this on there. It will also be a resource for all of you. I know sometimes it's difficult to get lots of folks from your organizations on, and so it's nice to have a recording that you can go back and watch. Want to let you know in March we will be having the MSW interns from both the University of Arkansas at Little Rock and the University of Arkansas at Fayetteville. We'll be hearing from them about what their internship has been like in primary care clinics, functioning in the behavioral health integration model. And want to tell you some exciting news. We are going to be able to offer a CEU for today's webinar, and we're really excited about that. We will have and I have to brag on our team and thank our team for pulling this together. And getting these CEU applications is a process, so thank you guys. We will have a QR code that we will put up at the end. That will be a link that you'll be able to access this. So there will be a learner notification with a QR code, and you'll have a process. So now we are going to turn it over to Dr. Gibson to introduce Mr. Botts.
Yeah, thanks, Kim, and welcome everybody. It's really amazing to see the quality of speakers that we've been able to bring to these ABIN webinars and to Arkansas. And so this is another one that I'm really excited to be able to have Chris Botts share with us. And I was really impressed, I guess it was in 2020, 2019, 2020, to see that the American Medical Association had established a behavioral health integration collaborative. And this was formed by several physician organizations, including the American Academy of Family Physicians, the American Academy of Pediatrics, the American College of Obstetrics and Gynecologists, American College of Physicians, American Osteopathic Associations, and American Psychiatric Association, as well as the American Academy of Child and Adolescent Psychiatry. And that's really relevant to me because often in mental health, we get very siloed and we think that this whole BHI, behavioral health integration, is just kind of a little small thing that we're going to do on the side. But this is a major way of approaching improving healthcare. So Chris Botts is someone that Kim and I've met the last couple of years at the CFHA, and so we welcome him. He is the Senior Manager, Care Delivery and Payment within the Professional Satisfaction and Practice Sustainability Group at the AMA. And in this capacity, he helps lead the AMA's efforts to advance new models of care delivery and payment, and that can improve the sustainability of physician practices by removing obstacles to patient care, helping physicians to learn, adapt, thrive, and lead, because we know that healthcare continues to change. And so the AMA BHI initiative and BHI collaborative is one of those efforts, and Chris has been leading that. So prior to joining the AMA, he worked at the Healthcare Reform and Innovation Administration with District of Columbia's Department of Healthcare Finance, designing and implementing new innovative health IT programs. And it's really helpful having people come from all parts of industry and knowledge. And so Chris bringing his knowledge to the AMA and to the BHI collaborative is important. So these programs that he worked with improve data integration and provide actionable information to reduce health disparities, enhance healthcare quality and outcomes, and promote wellness in the district. Mr. Botts has also worked at the Center for Health Policy, which was formerly known as the Engelberg Center for Healthcare Reform, at the Brookings Institution in Washington, D.C., where he supported the center's payment and delivery reform initiatives, including those related to the Medicare alternative payment models and health plan innovations. He has earned a Bachelor of Science, BS in Neuroscience, with concentration in pre-medical studies from the College of William and Mary. So many words that I've just stumbled over in so many places that are so far out, but what I do see so far from Arkansas, but bringing in this national expertise from other organizations, and especially the combination of data, outcomes, measurement, and how can we continue to transform healthcare to make it, at the end of the day, better for our individual patients and families, to feel better and function better and have whole health. So thank you so much, Chris, for being here, and thanks everybody for attending, and we look forward to today.
Fantastic. Well, thank you all so much for having me. I'm really excited to have this conversation. I think all of us on this call in these topic areas are just really passionate, right, around enabling more timely, equitable access to whole person care. And this is just part of one of those initiatives. And excited to kind of share some of the work that we've been doing. I think leading into this, as with all of these types of conversations, these are very kind of complex in nature. And just want to note that, I'm going to do my best to kind of summarize some of the things we're doing, but by no means want to pretend I know everything under the sun here. But hopefully this represents a lot of the work that we've been doing, lessons learned we've had, and some opportunities moving forward, and looking forward to also having a dialogue with you all about your thoughts, reactions to anything, and happy to take the conversation where folks find it helpful to go. So these are just a quick outline of the objectives for today. As noted, going to just talk a little bit about the BHI Collaborative and what we've been doing. Start, summarizing a little bit of some of the key lessons learned we've had over the 4 or 5+ years that we've been doing this work, and really kind of where we see some opportunities moving forward for stakeholders all across the healthcare ecosystem. This is just a quick overview of the collaborative. Really our mission is catalyzing effective and sustainable behavioral health integration in physician practices. I think, as Dr. Gibson noted back in 2020, our initial focus in the specific space was within primary care. But as I'll get to in a little bit, as of yesterday, kind of officially announced an expansion beyond primary care, and I'll talk a little bit about that. And I think the key part, really want to underscore, part of that is the catalyzing part. We recognize that this group that we represent are just one piece of the puzzle, that there are several organizations like yours that are working in this specific space, and want to make sure we are working across at least the House of Medicine to be a positive influence to be able to get to where we're all really trying to get to. And that really is kind of establishing this kind of identification of management of behavioral health conditions, particularly those are mild to moderate, is a core competency of physician practices rather than an exception, which unfortunate part that I think many of the folks on this call probably know that that's not the case today, but our goal is to try to make that the common rather than the exception kind of moving forward. Dr. Gibson already kind of noted who the members were when we established the collaborative back in 2020. And that was really from some conversations we were having about really kind of this increased recognition about the importance of tackling behavioral health within physician practices, and organically had conversations with these organizations to really understand they were either doing work in the space or these were high priorities within their membership, but really wanted to focus us on creating a more collaborative, collective effort that really can bandy these the expertise within these organizations together to have greater impact rather than working on them in silos and independently. As noted in red, we just recently expanded the membership to some additional organizations that represent specialties outside of primary care. And we feel that is really important, that behavioral health care just doesn't stop at the primary care door, that the importance of whole person care spans multiple specific settings. And I'll talk a little bit about that as well. These are kind of the four main objectives that we have as part of the collaborative. This is what we've kind of established when we were first created back in 2020 and have evolved since then, but it really focuses on kind of four main pieces. The first is around broad education. We continue to feel it's really important to be able to educate physicians and care teams about just the importance of behavioral integration, but not just the importance, but also opportunities and best practices to be able to implement today and moving forward to make, again, BHI a more standard part of practice moving forward. We also see an opportunity to be able to increase evidence-based solutions, especially to some of the key barriers that we continue to see in the specific space, and working on those solutions to ultimately activate practices as well as other key stakeholders to making this a reality. And then ultimately really want to ensure that pursuing these types of models enables better and improved professional satisfaction, knowing that physicians, the care teams, these healthcare organizations ultimately have the abilities to better support the needs that they see within their patients. And I think we've heard a lot about kind of some of the moral injury that often many of these institutions, practices, et cetera, recognize these needs, but don't necessarily have the abilities to tackle them. And that can really weigh on all the members of the care teams and really make it difficult to really feel like you're satisfied in your day-to-day careers. We've, in order to accomplish these mission visions and kind of ultimate objectives, we've organized our activities into four main buckets. Again, the first one is around this educational programming. There's a link here that I know the group will send around to everybody, so you have access to them. But we have a open access webinar series. I'll talk a little bit about that later today, but it really kind of brings together key experts from across the country to really kind of help raise awareness and share best practices from experiences on the ground that folks have been doing. We also want to be able to continue to either promote existing resources or fill in gaps that we've identified to really kind of help those that are trying to implement and sustain behavioral health integration. We've, again, created several different resources as well that I'll talk about a little bit later. We also know that there's still opportunities to grow and test new opportunities or ways to be able to tackle these barriers and solutions. We just are wrapping up a pilot immersion program that I'll talk a little bit about as well. But really want to focus on how do we help fill in gaps to be able to create the sustainable pathways that we're all looking for, which gets into the last area, which is, again, sustainability. And want to make sure it's clear that when we use the word sustainability, it's not just financing, which is a huge part, but it's really the totality of being able to do this in a sustainable way that really gets at some of the other key pieces beyond financing. Again, burden reduction, improvements in outcomes, experiences, et cetera. And again, talk a little bit about that later in the presentation as well. So first, real quick, I alluded to the fact that, when we first established the collaborative back in 2020, we really were focused on the primary care space, in part because we needed to start somewhere, and in part because much of the evidence base within this space is specific to the primary care specialty areas. But as we've done this work, it's become more and more apparent that the need for integrative behavioral health care goes beyond just the primary care setting. And these are just a few data points that, again, I don't think is probably surprising to many, but just underscoring the fact that, one, there are many non-primary care specialties that do manage large cohorts of patients that have chronic illnesses that tend to overlap with other comorbid mental health conditions. There are also many chronic illnesses, that just the diagnoses of them can also increase the risk of developing mental health conditions as well. And so we really feel like there's an important connection in these specific spaces, and also wanted to recognize the fact that I think when folks think about some of these chronic illnesses and comorbid conditions, they often think of older adults, but this is a need across the lifetime for people, that it also is very important in children, adolescents as well. I know that we've seen an unfortunate part, particularly within the pandemic exacerbations, particularly within the youth mental health crisis, but recognizing that it's not just, again, within these primary care settings, but there's some several other chronic areas that we think are really important to really raise awareness about the importance of doing true integrated whole person care. So as we were trying to think about spaces that we should start thinking about prioritizing beyond primary care, we really focused on those that provide longitudinal care, again, that manage these chronic illnesses that are significantly impacted by these comorbid mental health conditions. These are the 4 areas that we've focused on now. It doesn't mean that there aren't other areas that this is important, but as we prioritized and based on the research that we did and the studies that are out there, these felt like the top, kind of the ones that rose to the top, where it was really important to be able to kind of focus on opportunities to be able to integrate behavioral healthcare more than has been occurring to date. And as noted in the membership, the specialty societies that represent these agree, and they see that within their membership as well, and are excited to be part of our ongoing conversations as we build on much of our work moving forward. Wanted to spend a little bit of time to kind of summarize what we've learned thus far and the 4+ years we've really been working in this specific space together, recognizing that much of this work had taken place well before we established Collaborative in 2020. And before doing that, I wasn't sure exactly where everybody was within the audience here, but just wanted to kind of ground us, and especially the perspectives of the collaborative. We think it's really important to be model agnostic when it comes to the conversation of behavioral health integration. We recognize there is a strong evidence base out there, but there's a spectrum of models that are out there. And the ultimate focus, again, is increasing access to timely, equitable, and whole person care. And there are several ways to accomplish that. And there's strong evidence base within this kind of model spectrum that provide a North Star for practices to try to figure out how best to ultimately support their patient needs, especially based on what their current resources are. You know, as we had conversations across the ecosystem, really discovered that people are all over the place in terms of how they're approaching this specific space. Again, kind of from left to right, from more unstructured to structured, as well as starting to explore to more fully implementing them. And I think this is really important for folks to understand that it's not a monolith out there in terms of how people are trying to tackle these needs. I think there is a broad recognition, right, about the importance of tackling behavioral health care across these different settings. But I think there is still some confusion for folks about how to go from that recognition to implementation and ultimately to sustaining them for their care teams and ultimately their practices. These are just some highlights of some of the experiences that we've kind of elicited from these conversations. Again, I think it's not surprising that pretty much everybody recognizes the positive effects that implementing these models in their practices have, and ultimately recognizes the right thing to do. The challenge becomes the right thing to do doesn't necessarily mean it's the easy thing to do. And I think that's where some of our conversations have gone in terms of tackling some of these barriers to create some of these sustainable solutions. And as I noted, strategies within the space kind of span, right, these models, as well as different mechanisms to do that, from co-location to more virtual-based consultation, et cetera. I also wanted to note that the goals here really is trying to leverage these models as North Stars, but there are different ways to implement them that best fit the current resources or abilities of practices and systems, as well as ultimately what the needs are of their specific patient populations. And so want to really understand that there is some flexibility, right? As using the evidence base to really fit within the current needs as well as the future development to create that sustainability, and that evolves over time. So just because a practice or organization starts in one place isn't necessarily means that that's where they have to end up, but there are opportunities to start somewhere. The saying, don't let perfection be the enemy of good. I think many of the folks on this call recognize that these needs are desperate and needed to be tackled yesterday or before. So let's not let perfection be obstacles to be able to really get these types of integrative models out there that can improve care for patients. Here's some of the persistent barriers we continue to see. Again, I don't think any of these are probably surprising for this group. I think these are things that we continue to tackle. One thing that I really want to underscore is the last one around financing. That continues to be the top challenge that we continue to see and have conversations about, and have a number of questions that we have as part of our work really focus specifically on that area. So this is some of the key pieces that we've really discovered as part of those specific conversations. Again, there's no kind of one size fits all payment approach that has been effective to support BHI. Many folks use fee for service. And again, there's a lot of directions we could take this conversation, knowing that the collaborative care codes, for example, are fee for service based. And so for those that are pursuing that model, right, that's what many people use to try to implement and sustain their programs, and working across the different state, federal coverage programs, local commercial health plans, employers, et cetera, to be able to utilize the various different codes that are out there to sustain their practices. Others, on the other hand, are trying to leverage more of the value-based care arrangements, also known as alternative payment models, a number of different terms that are out there to be able to sustain those efforts as well. Regardless of whatever model people are using, there continues to be pervasive concerns. For example, on the fee-for-service side, right, using a number of those different codes, even with some of the collaborative care codes, folks can feel are too complex and burdensome. On the value-based care side of things, the challenges can be more isolating the impact and value that integrative models can bring to the more broad efforts that those models are pursuing. And so there continues to be those challenges in the space, and it's one of our priorities moving forward that we're trying to continue to tackle. So just a little bit of a summary as well. I think, as I noted, as part of our strategies, we want to make sure that we're working across the ecosystem to be able to create solutions that are sustainable. And that includes engagements with health plans, employers, and the like. I think it's important to understand that everybody kind of is still trying to figure out the best sustainable pathway in the specific space. Health plans, just like practices, have a wide range of experiences and different opinions about what their path forward is. Some are focused specifically on the collaborative care model. Some are more model agnostic. There continues to be additional conversations about how to use technology. I think we saw in the pandemic, right, the increased use of telehealth and virtual care within the specific space. And again, this continued conversation about what is the appropriate financing method to be able to create a sustainable pathway. Is it fee for service? Is it value-based care? Those conversations continue. And I think those are just underpinned by employers' continued frustration about just the continued fragmentation that mental health care for their employees face when they're trying to reach their support. And I think employers have tried a number of different activities to be able to tackle this fragmentation, and they continue to evolve some of those efforts. I will say that I think we've seen a little bit of a retrenchment of trying to do a lot of things and try to narrow down and simplify some of those activities so they're not adding to the already complicated space, and really being more enablers as part of facilitating more of those integrated whole person care approaches, moving beyond things like EAP programs, right, to ways to be able to really integrate the kind of no wrong door approach to their products and services they provide their employees. Um, I alluded to this as well, but one of the big things that we learned as the pandemic got underway is really the growth of technology and the support of these models. When we started this work and conversations actually back in 2018 and 2019, the utilization of things like telehealth were pretty minimal, even in what you would consider very tip of the spear type of programs. And that obviously flipped on its head as it has with much of the healthcare ecosystem. But there continues to be recognition that there's other technologies beyond just a telehealth that could be used as part of the BHI journey. And we have a report on this as well. Again, I could do a whole presentation just on this. But I think this is a conversation we continue to have. And I know that there have been additional conversations, at least even with some of the retrenchment of some of the rules and regulations around telehealth, that behavioral health continues to be the space that folks agree that having that flexibility moving forward in a standardized way is really important. As I also mentioned, we are wrapping up a pilot, what we called an immersion program, which was really a 12-month, primarily virtual program that brought together 20 plus experts from all across the country, all across settings, to be able to create a model agnostic curriculum to help organizations that have either never implemented BHI, perhaps previously tried to implement these models and failed for whatever reason, or at the very, very early stages of their implementation journeys where they still need a significant amount of help. So we brought together 24 organizations from across the country that spanned all types of settings, from independent practices to large systems, hospitals, FQHCs, academic medical institutions. And that was really intentional because we want to make sure that these models are feasible regardless of where folks are practicing, and that's really important. We also recognized that there are some nuanced differences between some of the populations that are being served, and just to facilitate some of the content, we established 2 specific tracks as part of the program, one specifically on child adolescent care, one on adult care. Even though there is some overlap in terms of approaches, we thought that was the best way to go about kind of organizing some of the specific content to ensure that it's as actionable for the audiences as possible. As I noted, we're still in the process of evaluating the program. We'll have a final report in a couple weeks, and we're still trying to kind of figure out the best ways to take lessons learned from the program, and happy to answer questions about what we've learned thus far as part of that effort. But I think one of the key things that we had coming out of the program is this establishment of these kind of 8 key elements or building blocks of behavioral health integration that, again, span regardless of what model or approach folks are taking. These 8 areas are key to be able to tackle in some way, shape, or form to be able to be effective and successful in those integration models. I'm not going to go through and read all of these, but we think this is really important to be able to kind of take some of the alphabet soup out of some of these conversations and ground it in truly what are the key pieces that are truly important that we're all trying to strive for, and then can retrofit some of these other kind of evidence-based models and measurements and others, building on these kind of 8 key building blocks. And these were established, again, working with those 20 plus experts from across the country. one of the things also noted was the challenge sometimes of evaluating the value that these models can bring. And so we incorporated a framework that the AMA actually established for digital health, but recognizing all the various different value streams that behavioral health models can bring to an organization, moving from things like clinical outcomes and access to care, but also patient and family experiences, the clinician experiences, and as I noted, the financial and operational impact, by recognizing that equity is a critical piece across all settings, that again, the goal is to really have that timely, equitable access to this type of care. And again, this is a lot of information, I know, but one of the things we started trying to do is trying to recognize some of the measurements that could be used across these different value streams. Some of these are used currently. Some of them are still, I think, being explored across these different kind of products and services. I think there are things that I recognize here and are used, like PHQ-9s and GAD-7s, but start looking at things like referral completions, or even net promoter scores for experiences, right? CAP scores, I know folks will be using as well. Measuring burnout within the clinical teams. All these things I think are key pieces to be able to track, to both evaluate how effective the models are, but also be able to translate those to be able to communicate the values moving forward, to ensure that these types of models and initiatives can be sustained moving forward. So speaking of moving forward, thinking about all the things that I just kind of outlined and things that we've learned in conversations we've had, the goal isn't just to recognize what's happening, but how do we change the current dynamic? I think we all recognize that the status quo now is just not acceptable. And that's why we're all here and trying to strive to be able to make this a more standard part of practice moving forward. So as we've had conversations and been thinking about all of the work that we've been doing, these are kind of the three specific areas that the collaborative recognize are kind of the areas of need that really need to be focused on, regardless of where you are in the ecosystem. And that falls into these three categories of education and training. Again, more access to dedicated resources to be able to help those on the ground to be able to do these things. Operational administrative requirements. We continue to hear pushback about the number of burdensome requirements and operational elements that make implementing and sustaining these models more difficult and detract from what those that are on the ground are trying to accomplish, which again is to improving timely access to care, which gets into the last piece is appropriate coverage and payment, that there has to be adequate coverage and payment, and the payment has to have built into it adequate margin to be able to sustain these models. Just because there is payment that exists doesn't mean that the abilities of those payments to cover all the implementation, especially upfront investments, is adequately covering those efforts, not just initially, but sustaining them moving forward. And so that's a conversation we're really continuing to try to evolve and have. Here's just some key specifics specifically around the coverage and payment piece. Again, I don't think any of these are probably surprising to many of you. Issues with out-of-pocket patient costs. I know that the state of New Mexico actually just put into regulation eliminating cost sharing for all behavioral health services. So very interested to see what happens with that initiative. Issues around narrow networks, workforce issues, right? All these things are coming into play that really trying to focus on. I also just wanted to note that the topic of value-based care continues to come up in the specific space. This was actually a study we did with the RAND Corporation back in 2020, and this is just a quote from that philosophically talks about the fact that behavioral health integration really better aligns with the philosophy and approaches of more value-based care arrangements than the fee-for-service style approaches. And again, this could be a whole separate conversation. Understand that collaborative care model codes are built in for fee-for-service and were developed to be able to really enable that in that specific space. So we probably could have a whole separate conversation and presentation on that. I think the thing that underpins this quote from 2020 is that looking at things today, while there's this recognition about the importance, and I think we've seen some recent movement from the federal government and CMS and CMMI and some of the models that they've been developing, whether it be the Making Care Primary model that has a explicit call out of behavioral health integration, or the recent announcement of the integrating behavioral health model as well. The amount of efforts and incorporation of behavioral health integration within these value-based care arrangements isn't quite where we would expect it to be, given this recognition of overlap between the philosophies of those arrangements and these types of models. So this is going to be a high priority for the collaborative moving forward, and is a high priority for all of the members that make up the collaborative. So part of what we tried to do, and this is developed from an external advisory committee that we brought together that represented a number of different external stakeholder groups, whether it be large employers, health plans, independent practices, large systems, patient advocates, is really, what do we do? How do we find real actionable solutions to be able to change and address some of the barriers that I mentioned earlier in this presentation? Again, I could have a whole presentation just on this, trying to give everybody a little bit of a flavor of everything that we've been doing. There are links in this presentation that folks can dive deeper into as well. This is just a little bit of a summary of some of the solutions that we've identified across these different stakeholder groups, and is really working across these groups collectively that the collaborative thinks is really important to be able to get to the ultimate place we're trying to get to within the ecosystem. Can't just do the practices, and health systems can't do it by themselves. The employers can't do it by themselves. It's all of these things working together in a timely way to be able to get to tackle those three areas that I mentioned, from education, technical assistance, administrative burden, and coverage and payment. So, again, I'm not going to spend an inordinate amount of time going through each one of these, but I think all of these are really important to be able to kind of work on. And we as a collaborative are working independently and collectively across these groups to take these solutions and try to put them into action. And we've had some really good conversations, but as you can imagine, it can be slow going. And so I think we're still trying to navigate the best ways to have make these solutions a reality. But I will say again, like the state of New Mexico, I think there's broad recognitions on some of these that folks are already starting to put in place already. So lastly, I'm just going to do a very kind of brief overview. One of the pieces of activities that we talked about is being able to create resources that help folks on the ground that are trying to do this. Then we really try to make sure everything that we're doing is based in the real world experiences of folks that have been doing this, to try to lower the gap from and spread these types of best practices and information all across the country. So, because right now, there's pockets of some of this effort, but we really, again, want to make it standardized all across the country. The first one is what we call the BHI Compendium. This is one of the first things that the collaborative released several years ago, and this was in reaction to some of the conversations we've had with many of those practices and folks that have been trying to do integration, that it was really challenging to even find the right resources to be able to help them where they are. There's pockets of different resources and things kind of all over the place, but it was a lot of effort to be able to navigate that. So that's where the compendium came in, is really taking what has been recognized as some of the best open source resources from all across the country, and organizing them in an implementation framework that allows folks, regardless of where you are in your implementation journey, to pick and choose what makes sense for you, and bringing in that information and linking to them to help make it a little bit easier for folks to be able to figure out what to do now and what to do moving forward. We're also really excited. In the coming months, we're actually going through a fairly significant update to this document, utilizing the lessons learned from the immersion program I talked about. I think we had some really great insights, particularly on hot topics like the financing from all of our various different subject matter experts and faculty from the program, and we're working to integrate all of that content into the compendium. So that is one way we're looking to spread some of these great lessons learned from the program. And that document is open source. Anybody can access it. And as always, trying to incorporate some real world examples to help show people that this isn't just something that's theoretical. These are evidence-based models and solutions that have been happening and are happening now, because that's a piece as well that we've heard that it's sometimes, and one of the lessons learned we've heard from the immersion program is many times folks feel like they're on the front lines alone, and you're not. And there are many folks across the country that are doing this, that are interested in doing this, and having that feeling that you're not alone and that there are folks that have been doing it in ways to learn from their experiences is something that has been really critical, that folks have been looking for as well. We also have again, open on-demand webinar series that we launched back in 2020. We have 25 plus topics that we've covered as part of these webinars, covering a variety of different topics from billing and coding to how to address health equity, psychopharmacology, suicide ideation, telehealth. And these are all presented and developed with subject matter experts from all across the country that are doing this, have been doing this. So it's a really great place to be able to pick and choose specific topic areas that would be helpful. Shameless plug for us, we have an upcoming webinar coming up in a couple weeks specifically focused on veteran health, as that's one of the areas that we've heard a lot of conversation about. So we're really excited about that presentation. There, as part of our conversations as well, there were a number of specific topics that folks really felt like the existing resources that were out there really didn't fit their needs. And these are the specific areas that we heard, again, range from psychopharmacology, substance use disorder, suicide prevention. So we have developed what we call these how-to guides, which are kind of supplementing that compendium that do deeper dives in some of the specific topic areas. And we're working on updating these as well, coming up this spring, just not as substantial as the compendium updates. And then lastly, one of the things we heard as well, particularly in the fee-for-service spaces, there's a number of different codes that can be utilized to help try to support these specific models. So we developed what we call this behavioral health coding guide, which takes many of the CPT codes that are in existence and organizes it based again on the model spectrum for co-location to collaborative, which really can help represent kind of what's out there and also discuss what the current rules of the road are, particularly knowing that there's been some changes because of the ending of the pandemic. So this could be a helpful resource as well to people as well. So that's all I have. I know that was a lot of information, really try to cover all the great work that the collaborative has been doing moving forward, but again, recognizing that we are not the be all end all. We want to be additive to this conversation, do what we can and leverage the expertise with the physician organizations we recognize, but also partnering with organizations like this and others to be able to achieve the ultimate goal again of that kind of timely, equitable access to whole person care. So just really appreciate you all having me today and happy to answer any questions or have any conversations about anything that folks would like to discuss. I know it's a lot to digest. So thank you so much.
Thank you, Chris. Yes, we do have a few minutes. If anybody has any specific questions, I've been taking notes rapidly and trying to go, okay, let me get this link, let me get that link. But we will be posting this webinar recording on our website, and Chris has graciously agreed to provide his PowerPoint, and we will get that information about the webinar that's coming up soon on the 24th. Any other questions or comments? We still have 38 people who are stuck with us and who are interested in this broad topic.
And typically we have lots of questions. So I wanted to ask, does anybody have any specific questions for Chris around, okay, one question, are all of those resources free, Chris?
Yes, yeah, I think that was one of the important parts of our strategy, was that broad education and engagement with everybody that is interested in pursuing these types of models. So all the links that will be provided are free and accessible, and can be utilized within your organizations however you see fit.
Wonderful. You know, one of the things that I think for me that really stood out as you talked about um, the importance of bringing everyone together to try and promote BHI, meaning we need to bring together practices and organizations, we need to bring together employers, we need to bring together policymakers, etc. Would you talk a little bit about any suggestions, guidance, advice you may have for us here in Arkansas? Here in Arkansas, we have we've been doing a lot of, a lot of work in the BHI space, but we're still struggling, as you identified, with some of the financial pieces for COCM. We don't, Medicaid has not yet turned on the codes. We do have commercial payers paying for those codes. But if you could speak a little bit to how do we bring these entities together, a little bit about some of the components of the secret sauce we need in order to get this further down the road in Arkansas.
Yeah. I would love to say there's like one secret sauce that's proven and developed. I think the unfortunate part is that if that existed, that we probably would have that already happening in all these various different kind of jurisdictions. I will say, across those different stakeholder groups that kind of talked about and represented, I think the unique thing in this space, and I think we know within healthcare this isn't always the case, there is the broad recognition of the importance of needing to do a better job to tackle this specific issue. And I do think that is an important, it may seem simple, but I do think it really helps facilitate those conversations, because it is coming to the table recognizing that something has to be done. The question then becomes, what do you do about that recognition? And I think that's where I think even within the space, our position, I'll at least speak for myself, is that I think we need to get away from this model versus that model, this versus that, right? That I think, and what we tried to do in some of those building blocks is really ground it in the ultimate need that we're trying to tackle, right? We all recognize that timely access to behavioral health care is just not happening to the degree that we want to. And there are opportunities within these various different care settings utilizing this evidence base to be able to do that. And I think helping educate the broader public and some of these entities to be able to understand that, I think, is important. And then trying to look at some of these key solutions. Not everybody's gonna be able to do everything. And even in the slide I had there, there's several other solutions we've identified as well. But starting somewhere, recognizing where there are things that happen, what is already currently happening in existence, and building from there, I think, is a key piece of that. I think the last piece, and that gets to kind of those value propositions, and this is something that we're going to be trying to work into the updated part of the compendium. But one of the modules we had talked about prioritizing certain values, but also recognizing what the values are of the key constituents that you're engaging with, and finding where those overlaps are and starting the conversation there. And again, I think folks will be surprised that there's more overlap there than people will recognize. And I think the other pieces are the benefits of what things like the collaborative can do is try to improve the broader ecosystem. I think there's some changes that just have to happen that individual organizations can't do on their own, but there are activities now that can happen that can get closer to the sustainability that we're trying to strive for. But I think that there are some unintended consequences. I think some of the requirements, right, for some of these programs have that I think even just educating folks on them can help find a common solution, because I think, again, not everybody wants it harder to get this type of care. I think just finding the pathways to do that is still part of that open dialogue that you just have to have happen. And sometimes it's just finding the right people to do that. And unfortunately, those change depending on what jurisdictions you're in. So I don't know specifically within Arkansas, but I guarantee you they exist. So, and hopefully the data and information in these materials can help empower those conversations.
Absolutely. I definitely think these materials will help provide some additional education and on the importance of this. I want to ask others, do you all have specific questions or thoughts or comments that you might have that you want to add?
A good comment in the chat was we need to bring the process to teaching medical schools, helping students and residents to buy into integrated health. And Chris, when you said sustainability is key, financial sustainability is huge, but it's not just about finances. And really, you keep going upstream that it's a change in attitude in our culture about the stigma and the way that our healthcare system is established. And we still are like, primary care and all these specialties have to change the way that they are thinking about addressing behavioral health, as opposed to thinking it's just this other department that you send people to. And then sometimes we'll bring those people from that other department into our primary care. So do you want to say a few more things about that piece, about what's the other parts of sustainability?
So I'm smiling. So one, we just had our first collaborative meeting of the year last month, and we were trying to figure out what other priorities we want to have. And I know that the recognition of undergraduate, graduate medical education and others, right, is a piece of that. We have to prioritize what we can do. So we've been trying to figure out how much we can tackle, but it's definitely a recognition that we've had even when we established the collaborative back in 2020. I was also smiling because the very, very first webinar we did was on culture. That one of the things we've heard, and that RAND study I had a link to talked about this, is just a cultural change, right, of doing some of this is really important on both sides, right, of the integrative care team, the other parts of the broader organization's care teams. I think the other piece is we have to find ways, and this gets to kind of that second piece we talked about that kind of operational administrative burden. These types of models can't be perceived as yet another thing adding to people's plates, right? It's just not sustainable writ large if folks are now doing social determinants of health, right, and thinking about how to do it in an equitable way, and behavioral healthcare and physical, right, is just too much to tackle, especially when they feel like those are independent initiatives. And so the goals and some of the things we've tried to do of some of the materials, right, of how do you incorporate these things like workflow and others to be part and parcel and leveraging what is happening currently, right? This isn't a new thing, and it does take some change, but that change can take some time. And as long as you have some ideas of what those steps are, that short-term pain can lead to long-term success. But often, folks don't understand what's coming down the pathway. And so these initial changes can feel like too large of an obstacle if folks can't understand that this is a thing that can be accomplished and the impact it will have on them moving forward. I think one of the quotes that has always stuck with me with a large integrated primary care medical group was they said that doing integrative care on the satisfaction of their care team members was the biggest impact that had on their day-to-day lives, more than things like bonuses or clinical to support tools, right? Because the feeling be able to empower these care teams to be able to actually truly be able to support the needs of their patients was huge. It was huge. And I think, and I've talked about this in many settings, and Patty and Kim may have heard this. I think being able to better measure even things like burnout and others within the care teams, I think are areas that could help empower these conversations, because it's not just impact on patients, it's in potential improvements within the care teams as well that I think will help create engagement and sustainability moving forward.
That's really helpful. I also have to say, and one of the things I know, I've been attending the value-based payment group, and I know you've encouraged us to really try to look at, are there ways that we could show outcomes? How are we going to measure this? And that's really critical, and it's been really challenging. It's really challenging in the behavioral health space, because we're not traditionally used to doing that type of measurement and looking specifically at measurable outcomes. And so I think that's a whole nother animal for a whole nother time. But I just wanted to bring that up. I think that that's really an important piece.
And it gets a little bit to the slide I had about kind of those value streams, right? And some of the potential measurement. And one of the pieces that we talked about in the immersion program is, if you look at that slide, that's a lot. That's a lot, right? And the subsequent slides were also a lot, right? And one of the things we really emphasized to the participants was pick a couple areas, right? Pick a couple areas that are priority values that you have. Maybe your key piece is just access, right? Access is really what you want to be able to show measurement. You've increased access. That's a priority. And that's what you'll focus on and measure, and then show that you've had impact there. And then over time, you can add some of these other elements and value streams to it. And I think that gets to the prioritization and understanding what may be a priority for your leadership, right? Your care team members, others, but not feeling like have to do everything under the sun. And I think the other part that I would just emphasize, and I think is a key piece, at least from our end, is that flexibility, that it's not just these monoliths of these programs that you just plop down and it's the same everywhere. They really aren't, and they shouldn't be, because they should be incorporated based on the current resources that organization has access to, matched with the identified needs within their patient populations. And really empowering folks to be able to figure out what works best for them and their patients, I think is really important, underpinned, right, by the evidence base that is out there within some of these specific models.
I know we're getting down to the end of our time today.
Yeah, I was going to say, well, can we just go to coffee right now and finish, have another hour of discussion? This has been really, really good.
It really is.
And I know this was a lot, try to cover everything. Happy to, as people continue to digest it, help answer questions. I think the other part is that, even us being invited to come here, I think, is just, again, shows the recognition and the need for cross collaboration. And so we want to continue to help be part of those conversations and solutions. So input for us in terms of experiences that you all have and feedback or conversations you're having or lessons learned are all part of this process that we want to use our opportunities and the membership we have within the collaborative to help raise awareness and spread this information. And we aren't pretending like we established everything that I presented here, but what this is representing what we've heard and the conversations we've had and working on being that catalyst so it spreads, to folks like our places like Arkansas, right, to then other places from across the country. Because too often we hear, oh, it's great in this one area, but it's not happening in this other part of the country. And that's not how healthcare works. We want that to be the baseline wherever people are, that this is something that people can get access to. And this is just part of that solution to make the reality happen.
Well, we can't thank you enough for coming here today, for sharing the work that you're doing. I'm excited to look at the updated BHI compendium. I referenced that a lot, knowing that there are these wonderful free resources that are available. I'm sure our practices are going to be getting on your website, using these links. And I wanted to say, my apologies, we do not have a QR code that we will be putting up, but Jenny has put in the chat the link for the CEUs. And so please get on that link and that will connect you to get your CEUs today. Thank you so much, Chris. We appreciate your time and we appreciate all the work that's happening out there nationally on BHI.
Thank you all so much. Thanks again for having me.
Thanks, everybody.
Take care.